All right, we're going to get started. This is more or less very basic for our fellows, trying to kind of give you basic information about different type of shock, assessment, some management, some recent data about the fluid therapy, pressure therapy for shock. I have nothing to disclose. So if you know any pharmaceutical company that needs a speaker, let them know. I don't have any. There you go. So first we're going to talk about the definition of shock. It's simply you have circulatory failure, you're not able to deliver blood to the organs, and utilization of the organs of oxygen utilization, of course, is diminished, which results into rise in lactic acidosis. And you see some signs of hypoperfusions in organs as a result of this shock. You can have shock with normal blood pressure, and you can also have hypotension without shock. Typical patient that have probably hypotension without shock, like liver patient, their blood pressure will be 80s, 90s, but they're not in shock. That means that they don't really have any hypoperfusion or sign of hypoperfusion. Okay. We're going to start with a question. Which of the following is true regarding pulse pressure? Number one, pulse pressure is decreased with high cardiac output. Pulse pressure correlates with stroke volume. Pulse pressure is increased with cardiogenic shock, or pulse pressure is increased with hypovolemic shock. We should get the clicker. I forgot that. But anyway, you can tell me. Its answer is B. So, of course, the pulse pressure will be increased with the high cardiac output, and will be the reverse, decreased in cardiogenic and hypovolemic shock. So this is the equation that you studied in medical school. The MAP is the cardiac output times systemic vascular resistance. And when you have hypotension and shock, you can be either because of the low cardiac output or low SVR. Cardiac output is your heart rate times stroke volume. So, and the pulse pressure is the difference between the systolic and diastolic blood pressure. Types of shock that you're going to be clinically seeing in your practice. These are the four types of shock: cardiogenic shock, hypovolemic shock, distributive shock, or we call it vasodilatory shock, so there's another name for it, or obstructive shock. The most common one, distributive shock or vasodilatory shock, and then you have about 15, this is 2/3, about 15% of the cardiogenic hypovolemic, and very few percentage of obstructive shock with tension pneumo or cardiac tamponade. So you're going to be seeing this a lot. So that's the main one. Okay. How you diagnose shock? I divided this to you so you can see in real life what you need to do. You have clinical signs, you have some hemodynamic, and also some biochemical signs. And you can easily get these quickly in your ICU. The clinical signs, of course, you see the signs of shock: low blood pressure, MAP is low, systolic is low, tachycardia. The hemodynamic shock, you're looking for signs of hypoperfusion. So the three organs that you look for is brain with altered mental status, the kidney with decreased urine output, and the skin. So these are easy to look at and evaluate. These are signs of hypoperfusion. And the biochemical, the most common one is the one that we do here, lactate level. There is point of care lactate, which is quick to get. I don't know if in your institution if you do have that, but this can be within 30 minutes you can have the results. Remember, the normal lactate is 1. And we take 2 as the cutoff for the definition of sepsis and 4 for the severe sepsis, but The normal lactate is 1, so anything above 1.5 or sometimes even 1 is considered abnormal. That can be used as a tool for you to define shock. So you look for clinical, look for signs of hypoperfusion, clinically, decreased urine output, altered mental status, skin, decreased capillary refills, and look for the lactate level. This is from the New England Journal article, and this is basically just the same thing that I told you about, the different type of shock, obstructive, cardiogenic, hypovolemic, and distributive shock. And again, it's the percentage that I mentioned to you. I apologize, maybe it's not very clear, but it's basically summarized what I've told you. I'd like for you to look at this and maybe try to define or differentiate different type of shock in a simple way. So you have the cold, clammy, and you have the warm extremities kind of shock, and that can be easy on the bedside to kind of differentiate. So if you go on this route of the warm extremities, bounding pulse, this is basically the distributive shock in or vasodilatory shock. So this will be the most common cause will be the sepsis. If you're on the cold, clammy extremities and thready pulse, you're looking at a low cardiac output state versus the high cardiac output here. And then you can look into the intravascular volume. So you're looking at the GVD, crackles. If you're in this area, they're going to be heart is full. That means it's cardiogenic. If the GVD is down, patient has orthostasis, then that's hypovolemia. It's very simple. You can look at the extremities and try to determine where you are. This is another way of differentiating shock. So when you approach that patient that comes to you with low blood pressure, we talked about the clinical signs. These are the clinical signs that you look for. Try to get a history that may give you a clue. Fever, signs of infection, chest pain for cardiac problems, recent illness, comorbidities, medications, toxins, surgery, hospitalization, and so on. Some of the hypoperfusion signs there about the CNS with altered mental status, the skin, the urine output that's decreased. Look at the cardiovascular status, GVD, heart, abdominal pain, rigidity, and the urine output, which can give you a clue about the decreased perfusion. You can investigate more if you're not sure. So if you're looking for infection, you may consider the wound culture, the lumbar puncture, looking at the CT of the head, for sinuses, abdominal series, of course, if you're looking for intra-abdominal source, and cortisol level can be used as well. And the fibrinogen, of course, for the massive PE and D-dimer. So the next question. Acute right ventricular failure with pulmonary hypertension may occur with right ventricular infarction, cardiac tamponade, ARDS, adrenal insufficiency. So it's acute right-sided failure with pulmonary hypertension. ARDS, okay. Correct. So the clue here, with right ventricular infarction, you don't get pulmonary hypertension. So you will have the elevated GVD, but you won't have the pulmonary hypertension. With ARDS, you will have the right ventricular afterload is increased, but you also have the pulmonary hypertension from increase in the pulmonary vascular resistance. That's the difference between these two. Now, with right ventricular infarct, you have higher mortality, you have higher risk of cardiogenic shock versus the ARDS, but these are the difference between these two. There is no pulmonary hypertension with right ventricular infarct. Just picture here, I'm sure all of you or some of you have been doing this bedside or point of care ultrasound. This is basically just showing you right ventricular enlargement here on this view here, and this is the long axis parasternal view, and again the right ventricle is enlarged here. So that's basically when you do your bedside echo. Another apical 4 chamber. You can see how big is the right side versus the left side. Again, signs of right ventricular enlargement. We're going to go to the next questions. Hypotension accompanied by increased cardiac output may occur with. So you have shock and cardiac output is high. That's occur with what? You have cervical spine, liver failure, tension pneumo, cardiac tamponade, hemorrhage. So the vasodilatory shock is the most common cause of shock. We talked about this. 2/3 of the cases of shock you're going to see is this type. Sepsis is the most common cause of that, 80%. So 80% of the causes of vasodilatory shock or distributive shock is sepsis. The other causes, keep in mind, the liver, that was in the questions, pancreatitis, source of SIRS, trauma, thyroid storm, AV fistula, Paget disease, thiamine. These are all the remaining 20%. So anytime you see a patient with high cardiac output failure, high cardiac output hypotension and shock, think about these causes. Always exclude sepsis because it's a common cause, but also look for these. We deal a lot at Jewish with these patients. We have a lot. And remember, these patients have high risk of infection to start with. So they are not only have this chronic liver disease, but they also have higher risk of infection, and you have to be looking into that. Obstructive shock, common cause of this will be the tamponade and tension pneumo and massive PE. The difference here between these two clinically, this one here, you'll have normal LV function, venous return will be reduced. This one will be normal LV function, but increased ventricular afterload with the massive PE. So clinically you can differentiate, you can do an echo. It's easy to look into these and find them. This one also you can signs of right ventricular overload on the echo as well, that you can see at the bedside. That's why we use this point of care ultrasound a lot in the ICU. I'm sure all of you probably have seen that in your institution. Some other categories of shock that you need to be looking into it. Adrenal insufficiency. Nobody really does this anymore. The concentropin test. Everybody looks at the random cortisol if you're suspecting that. You're going to see two numbers, if 25 and 18 as a cutoff for the adrenal insufficiency. I think everybody agrees that if patient has shock, that's mount stress response, and for that reason, if your adrenal or random cortisol is less than 25, you probably have some relative, what we call it, relative adrenal insufficiency. So you can look into this. So you use this as your guidance. We stopped doing this concentropin. Spinal cord injury can give you venodilations, bradycardia, especially if the injury is above T4, because you're losing your cardiac sympathetic input. You can also have more than one type of shock, and this is common as well. You can have septic cardiogenic shock. You can have septic hypovolemic shock, so always look for that. It doesn't have to be just one type of shock. A patient can start with septic shock and then have myocardial suppression from sepsis. So you have sepsis early on, purely high cardiac output, and then a few days later you'll have decreased cardiac output with sepsis with cardiogenic picture. So you can have both. Your goals of therapy should be very clear in your mind in the ICU. You try to get a minimum target blood pressure. You're going to have to try to achieve that. You need to optimize tissue delivery or oxygen delivery, and you have signs to look for, clinical signs like improved urine output and lactate will be coming down. Stabilize the patients and de-escalate your measurements as the patient improves, whether it's de-escalated antibiotics or the fluid and so on. I gave you two mnemonics here. I like this one. Everybody feels good about VIP because you're a VIP doctor. But there's two mnemonic that I found. Either you use this one, airway, breathing, circulations, adequate oxygen delivery, and then you have end point, meaning that you're going to stop and de-escalate. Or you can use this one, ventilation, infusion of volume, and support of the heart. That's basically the mnemonic. Choose whatever you like. It's up to you. As long as you understand what you need to achieve here. Make sure you have a plan when you have a patient comes with this low blood pressure. So how are you going to stabilize the patient, work them up. Make sure ventilation is very important. Work of breathing, consume significant cardiac output so they cannot be in shock and they're still spontaneously breathing, so you need to support that. Take this work of breathing out of the equation. And you're going to intubate, of course, and work the patient up. Volume, anybody should be getting volume, even if they're cardiogenic shock. They're not going to die if you give them 500 cc of fluids, okay? They already intubated them, you already took care of the oxygenation, and you intubated them. If you don't know what's happening, just give them volume. Nothing is going to happen. After that, you can decide if you want to be giving more volume or you want to be holding off. But very important, the intubation. You have vital organ hypoperfusion and you want to rest the ventilatory muscles, of course, and you want to protect the airway with the mental status that's diminished. That's another reason to intubate. Of course, when you're intubating, the hypertension can get worse. That's because of the sedative that you use for intubation and for sedations. And also the positive pressure of the vent can decrease your preload. So these are all things that you have to expect that can happen when you intubate the patient. You can give volume before you intubate them while you're getting everything set up. If you have access, if you have lines, just give them some volume. Some of the medication that you even use, or most of the medication that you use will lower your blood pressure, whether it's going to be benzo or analgesics. Even if you're using non-benzo or non-analgesics medications, it can sometimes cause adrenal insufficiency. So be careful. Make sure you have a plan how to take care of this hypotension as you intubate. All right, so number one, we said the ventilations. Number two, the infusion of the fluids. So several questions you're going to have to really try to answer. First of all, how much fluid you're going to be giving? What are the parameters that are going to guide you to either give more fluid or stop giving fluids? And then what kind of fluids? And there's so many studies talking about these. I think if you read about the new data, this is all related to this. What kind of fluids? How much fluid? So I tried to summarize for you some of the recent stuff here. So again, volume is a cornerstone. Even in cardiogenic, give them fluid. Nothing's going to happen. Doesn't matter if you don't have the diagnosis early on. Give everybody fluids. 500 cc of whatever fluid you're going to choose. We're going to talk about some of the evidence about the fluid, but just give them fluid. Your guidance to continue adding more fluid should be based on, this is the recommended guidance. You're going to have to use what we call dynamic measurements of intravascular volume rather than static measurements. The static measurements are the CVP, SWAN. The dynamic measurements are measuring maybe pulse pressure variation, stroke volume variations, measuring IVC diameter change. These are the dynamic measurements that you use, what we call point of care ultrasonography. Whatever protocol, it doesn't matter as long as you know what you're looking for and what you're trying to do. Cardiac output monitors, they are all available now, the new ones, the Vigileo and other stuff, they're available in your institution, and they all give you this pulse pressure variation, stroke volume variation, and give you an idea about the intravascular volume in relations to the change of intrathoracic pressure. So it gives you an idea about whether the patient is dry or not. So that's what everybody agreed on. You're going to see a lot of technology coming out, a lot of people coming to your hospital giving you all kind of data about different devices. I don't care what you choose. I don't have any interest in any of them other than use whatever you think you understand and your hospital provides you. Each one of these devices have their own data that support their use. They all have algorithm and software that give you this information. I don't have any financial interest in any of them, as long as you know how to use it and you know also how to apply this information that comes from it. Some of them, of course, you have to understand the mechanism like visual IO. You have to have a regular heart rate. If you don't have a regular heart rate, the measurements of this cardiac output and stroke volume is not going to be accurate because it depends on this heart rate to being regular. You have to have used high tidal volume to get to see this variation between the inspiration and expiration. So you cannot use a 6 ml per kilogram tidal volume and you try to see the stroke volume variation. You need to use a higher tidal volume. You also have to have the patient passively ventilated, not actively ventilated. So you have to take them off completely, either heavily sedate them or even paralyze them so you can measure this. So you need to understand each device, how it works, and how the information are relayed to you so you can understand how to apply these. So whatever you have in your institution, use it. If you don't want to use it, use the ultrasound, which again, it's available everywhere now, and you can always look at the IVC for a surrogate of intravascular volume. Now comes the big question, what fluids? So there's several studies. I'm giving you the old one from 14 years ago, but it's crystalloid, colloid. Everybody, according to this old one, there is no really difference, and crystalloid is as good as colloid, so we don't really particularly resuscitate patient with albumin. And then we have a newer one 4 years ago. It's called Albius trial, but they used saline plus albumin versus saline alone. So they gave the albumin on top of the saline and looked for, they have actually 1,800 patients. They looked for death, mortality, and morbidity, and they found no difference. So adding the cost of colloid on top of the crystalloid didn't really give you any added benefit. The most important thing is that you need to infuse it quickly, within 20-30 minutes, regardless of the type of shock, and then you do the frequent assessment utilizing any of these tools here. The most recent trial that our fellows discussed in the journal club just recently was about what kind of crystalloid. So you have saline, and then you have the balanced crystalloid, which is basically lactate ringers. Is it lactate is better than saline? And according to this single center trial, the balanced crystalloid was superior. They were looking at mortality, they were looking at renal failure and need of continuous renal replacement therapy. And in their particular study that was published about 5-6 months ago, the lactate is better. Now remember, lactate has less chloride, which will provide you with less incidence of metabolic acidosis, the non-anion metabolic acidosis that you can get with saline, and this will decrease the renal vasoconstrictions that happens with that, and for that reason, this is the result of this positive results on this. I think you need to probably individualize your care, look at your patient, look at their labs and data, understand the potential complication of infusing normal saline. This is high salt, high chloride. So this is a study that gives you a clue here that maybe lactate ringers in certain patients will have a better survival. This is another question. 65 years old, admitted with hypotension despite fluid resuscitation. History of coronary artery disease, colon CA. Point of care ultrasound is done, and this is what it showed. Again, it's parasternal long axis, and just to familiarize you here, this is left atrium, left ventricle, outflow tract here, right ventricle, and there is something there. I'm not going to point it, but hopefully you see it. What's the cause of shock here? Yeah, so this is echo-free space here, tamponade. And this is probably the history of the colon cancer. And this, of course, the question is asking you what you do. Remember, again, fluids. Nothing going to happen, you give them fluid, but you're going to need to plan for this one. So that's the answer. Another image here again of tamponade. This is, again, utilizing the point-of-care ultrasonography as a tool to assess. So this particular patient is in shock, and you're seeing this on lung ultrasonography. So what's the cause of shock here? And what's this, what you're seeing here? What's that? Yeah, so you see this cone shape, this pleura here, cone shape, B-lines, multiple ones. So as you think about the heart, always look at the probably cause of the shock here will be cardiac. So we finished the ventilation, we finished the infusion of fluids. Now we're going to talk about the support of the heart. So we have inotrope, and if you're using the inotrope because the patient has cardiogenic shock, dopamine is the agent of choice for low cardiac output state. You're always going to need to look at arrhythmias, correct that, especially if it is like severe AFib with RVR. You can try to correct these and support the blood pressure. So correct the arrhythmias. If you're going to be using inotrope, will be dopamine. If you're going to be looking at just to support the blood pressure for pressors, several also articles have been looked at for what are choice of pressors we're using. I'm not sure how many of you use this, but for us it's probably dead already. Nobody uses that. That's from like 8 years ago. So they compared the dopamine to norepi, and norepi was superior. So that's the preferred pressors that we use. We don't really use dopamine anymore. The norepi, if you remember, it's mainly alpha, but it has some beta characteristics. So it's like maybe 3 plus, 1 plus, 3 plus alpha, 1 plus beta. So at high dose of norepi, you can have arrhythmia. So that's something that you just keep in mind. But still, it's number one preferred agent for pressors. This is just the study that I showed you about dopamine and norepi, and basically there is really no difference. We have some, you get some more, in this particular study, you get some more complication with the dopamine. That's why it was deemed that, again, mortality the same, deemed that the norepi has better side effects profile. Then another study looked at the vasopressin and role of vasopressin in shock. So you have the vasopressin versus norepi in septic shock. The key here, they did like an interim analysis of this study. So they randomized patients to the vasopressin alone versus norepi in septic shock. And the people who have severe septic shock, the vasopressin was inferior to norepi. With the people who have mild septic shock, the vasopressin was better. But if you combine all patients together, there is really no difference. So that's basically the result of this. A large trial. The type of patient or type of shock or the severity of shock can determine what you use. We still prefer in our practice here, we use norepi for everybody as a first agent, and then we are adding, or we add vasopressin as a second agent if we need another pressors. Vasopressin is usually used in a fixed dose. It's 0.03 microgram per minute, or 0.4. So it's 2.4 units per hour. So it's a fixed dose. You don't titrate or anything like that. Norepi, of course, you can titrate. Again, this is the study, and you can see here survival is better in the low septic patients versus the norepi, but they're overall, again, the p-value is not significant, but it is significant for the patient with low septic shock or less severe septic shock. The high is the one that has the other way around, the opposite. And the most recent one from last year, it is not commercially available yet, but it's angiotensin II for treatment of vasodilatory shock or septic shock. So basically, all the patients received a dose of 0.2 microgram per kilogram of norepi, everybody, and then half of them, they added angiotensin II, and the other half received placebo. And they compared, basically, their endpoint was at 3 hours, how many patients they were still hypotensive and did not achieve the target MAP. This is their endpoint. And the patients who received angiotensin on top of the norepi, 70% of these patients achieved this target MAP within 3 hours. And the patient who did not receive the angiotensin, only 23% achieved this target MAP. So adding the angiotensin II on top of norepi optimized your blood pressure, and you were able as a physician to go down on the dose of pressors and achieve your target MAP quickly. That's the results. The problem with this study, it's again small number of patients, only 300 patients, exactly 340 I believe, half of them in each group. So we don't really have any more data about this. The drug itself is not commercially available yet. I believe there will be probably more trials or large trials on this angiotensin, and maybe they're going to try to look into mortality. Right now, because of the small size, they are just looking at a target MAP at 3 hours. And this is basically the groups here. You can see the mean arterial pressure when the angiotensin is higher than the placebo, and also the change in the vasopressin, the vasopressor that you're using, the norepi, you're able to wean this quicker with the angiotensin versus the placebo. So that's basically their endpoint. Again, I think this is probably a good study to prove the concept of this, but I think we're going to hear more about that. I know that the authors of this trial, actually, they have their own pharmaceutical company now, and they're going to manufacture this drug, and they're not going to have to work for the rest of their lives, and if this work out. But I think it's going to be something to look for in the future as something to add into the treatment of vasodilatory shock. Let's take another question. 7 years old, chest and abdominal pain for 12 hours, blood pressure is low. I'm sorry about the spelling here. 4 liters of fluid we're giving, and somebody who's still old-fashioned used the SWAN, but that's okay. You're going to see this is still on your exam. There's still a lot to have this SWAN number there. You have a right atrial pressure of 14, pulmonary artery of 30/20, wedge of 18, and cardiac output is this. Most likely cause of hypotension is very simple. Should be simple for you guys. What's the cause of the shock? Come on. Cardiogenic shock. Thank you very much. All right. For the fellow candidate, if you don't get this correct, you're not going to take it against you. Trust me. Nothing wrong about trying. Healthy, 80 years old, admitted for altered mental status and hypotension. She had not been seen by her family for several days. She's hypothermic. This is the blood pressure. Give her fluid. She's still hypotensive. Again, you have right atrial pressure is low. I'm telling you now, it's low. Pulmonary artery pressure is also on the low side. Wedge is this, and the cardiac output is 7, which is high. The cause is sepsis. Thank you. One more. I didn't know that I have all these questions. 60 years old, intubated for severe respiratory distress for COPD. Sedated on the vent. Now, this is the vent setting. You have respiratory rate of 20, you have tidal volume of 600, which I don't think we have used this amount. But anyway, this is what the question is. FiO2 is 40. And then after 15 minutes, she becomes tachycardic, hypotensive again. Clear lungs, no pneumo on the x-ray, I'm telling you that now, and this is her gas. What do you need to do? So what happened here, and what do you need to do? First, what happened? Just forget about the question. What happened? What's that?
Dynamic hyperinflation?
Yes. So dynamic hyperinflation. So look at this minute ventilation here. You have 600 times 20 is like 12 liter. So you have 12 liter of a minute ventilation in a patient who's COPD, or I'm telling you here it's obstructive. So that's probably have created what we call dynamic hyperinflation auto PEEP, right? And this auto PEEP is probably responsible for this. A simplest way, other than these, just disconnect them from the vent. Nothing gonna happen. You disconnect them from the vent until you change your setting on the vent. They'll be fine, okay? Disconnect from the vent, and then you can decrease the respiratory rate, or you decrease the tie-up volume, or both. The idea is that you're gonna need to minimize your minute ventilation or decrease your minute ventilation. So this is basically the answer, is that you need to decrease the respiratory rate. So I'm gonna summarize the shock for you. Assessment, we talked about the clinical, and we talked about the laboratory and hemodynamic monitoring. These are the early things that you can use. Look for signs of hypoperfusion, look for the lactate level. Utilize your point of care ultrasound. You need to have a plan of therapeutic intervention. Remember the VIP, mnemonic, ventilation, secure the airway, give the fluid. Decide about the fluid, whether it's going to be continuing fluid or not, based on this dynamic measurements we talked about, using ultrasound, using hemodynamic monitors like Vigileo. Follow the urine output, lactate, mental status. And it's a moving target, so you need to have frequent assessment. You can go back and forth and give fluids, wait for a couple of hours, go back again, look and see, reassess with the ultrasound, look at the IVC, give more fluids, and so on. So this is something that you just not going to give an order and then come back the next morning for another order. I mean, this is something that you're going to be going back and forth to kind of assess. Always have this lactate measurements. We do lactate frequently, sometimes every 4 hours or so, early on, to kind of give us a clue if the patient perfusion is improving. So we have that capability, and I'm sure in your institution you do the same. So we have, you need to kind of have frequent assessment. This is the summary. I believe this is my last slides. Because it's still my last slides. Okay, that's it. Questions? Questions? Any question?
One thing that recently came up, so vasopressin is a potent splanchnic vasoconstrictor. And I heard anecdotally from surgeons that if you have someone who you think may be having gut ischemia, you should potentially, if they're on it, stop it, or if they're not on it, choose another pressor.
And it's the same for the coronaries, by the way. Yeah, so it's the same thing, vasopressin, you have to be careful with the coronaries. That's why we don't escalate. I had seen a patient that for some reason somebody went up from 0.04 units per minute to 0.08. That's doubling the dose, and the patient ended up with MI. So it's not only causes constrictions of the gut, but also can have the coronary problem as well. That's why it's supposed to be just fixed dose, but you're going to have to be careful for selected patients. And that's why I think the study that was done comparing the vasopressin to the norepi was just trying to address which one is superior. I think even for me, for the less severe septic shock, I'm still using or tempted to only start norepi as a first line rather than vasopressin as a first line. So it's always been the norepi. It's also has been in the guidelines, the sepsis guidelines. You will find that that has not changed since 2008 or 9. The sepsis guidelines also recommend norepi as a first line. So you need to be careful with the vasopressin for sure, and make sure nobody write orders about escalating the dose. Now they use it in the cardiovascular ICU in a different indications and different dosage. So I just want to make sure if you are rotating in a new institution that they are using it in a different way for their cardiac patient. So for us, fixed dose, probably not the first line. All right.